Imagine this. You've navigated decades of hormonal changes, raised a family perhaps, built a career, and finally reached a stage of life where you have the time, wisdom, and confidence to truly enjoy yourself. Yet there's an uninvited guest that keeps showing up in your most intimate moments: pain. You're not alone. Studies show that up to 84% of postmenopausal women experience some form of sexual discomfort, yet fewer than 25% seek treatment for it. Here's the truth that nobody talks about enough. Pain during intimacy after menopause is not an inevitable part of aging. It's not something you just have to live with. And most importantly, it's treatable. In this comprehensive guide, we're going to break down exactly what happens to your body during and after menopause, why intimate pain occurs, and most importantly, what you can actually do about it. We'll explore evidence-based solutions backed by medical research, from simple at-home remedies to cutting-edge treatments that are changing women's lives. Before we dive in, if you're finding this information valuable, please subscribe to our channel and hit the notification bell. We're dedicated to bringing you honest, medically accurate information about women's health topics that matter to you. Your subscription helps us continue creating content that empowers women to take control of their health and wellness. Now let's talk about what's really happening in your body and how to reclaim comfortable, enjoyable intimacy. Understanding the menopausal transition. What's really happening? Menopause marks the end of menstrual cycles, officially diagnosed after 12 consecutive months without a period. The average age of menopause in the United States is 51, though it can occur naturally anywhere between ages 40 and 58. But the changes don't happen overnight. Perimenopause, the transitional period leading up to menopause, can begin up to 10 years earlier. During this transition, your ovaries gradually produce less estrogen and progesterone, the two primary female sex hormones. According to research published in the Journal of Clinical Endocrinology and Metabolism, estrogen levels can drop by approximately 90% after menopause. This dramatic decline has profound effects throughout your body, but particularly in your vaginal and vulvar tissues. The genitourinary syndrome of menopause, GSM. What used to be called vaginal atrophy now has a more comprehensive medical term: genitourinary syndrome of menopause, or GSM. The International Society for the Study of Women's Sexual Health adopted this term in 2014 to better reflect the widespread nature of these changes. GSM affects up to 50 to 84% of postmenopausal women, according to a 2018 study in Maturitas. It encompasses a collection of symptoms involving the genital and urinary systems, all related to decreased estrogen levels. These include vaginal dryness and decreased lubrication, burning and irritation of vaginal tissues, thinning of vaginal walls, vaginal atrophy, loss of vaginal elasticity, narrowing and shortening of the vaginal canal, changes in vaginal pH, becoming more alkaline, increased susceptibility to infections, urinary urgency and frequency, recurrent urinary tract infections. Unlike hot flashes and other menopausal symptoms that often improve with time, GSM is a progressive, chronic condition that worsens without treatment, as documented in the Journal of Sexual Medicine. The physiology of pain during intimacy. To understand why intimacy becomes painful, we need to look at what estrogen does for vaginal health. Estrogen receptors are abundant in vaginal tissue, and estrogen performs several critical functions. Maintaining tissue thickness. Estrogen stimulates the vaginal epithelium, the tissue lining, to produce multiple layers of cells. Research in menopause. The Journal of the North American Menopause Society shows that after menopause, this epithelium can thin from approximately 200 to 300 micrometers to as little as 50 micrometers, a reduction of up to 75%. Promoting blood flow. Estrogen enhances vascular perfusion to vaginal tissues. A 2019 study in climacteric demonstrated that postmenopausal women have significantly reduced blood flow to the vagina, which impairs the natural engorgement and lubrication response during arousal. Stimulating lubrication. Vaginal lubrication during arousal is a transudate fluid that passes through blood vessel walls in response to increased pelvic blood flow. With less estrogen and reduced blood flow, this lubrication mechanism becomes significantly impaired. Maintaining elasticity. Estrogen promotes collagen production and tissue elasticity. Studies using vaginal elasticity measurements show that postmenopausal women have significantly reduced tissue distensibility, making penetration uncomfortable or painful. Regulating pH. Healthy premenopausal vaginal pH ranges from 3.5 to 4.5, maintained by lactobacilli bacteria that convert glycogen to lactic acid. Estrogen stimulates glycogen production in vaginal cells. Without adequate estrogen, the pH rises to 5.5 to 7.0, creating an environment less hospitable to protective bacteria and more prone to infections. The medical term for painful intercourse is dyspareunia, and it manifests in different ways: pain at the vaginal entrance, introital dyspareunia, pain with deep penetration, deep dyspareunia, or burning and irritation during or after intimacy. Beyond the physical, the psychological impact. While the physical causes of painful intimacy are well documented, we cannot ignore the psychological and emotional dimensions. Pain during sex creates a complex cycle that affects multiple aspects of well-being. Research published in the Journal of Sex Research describes a predictable pattern. When intimacy is painful, anxiety about future encounters naturally develops. This anxiety triggers a protective response. The pelvic floor muscles tense involuntarily, a condition called vaginismus. This muscle tension makes penetration even more difficult and painful, reinforcing the anxiety and leading to avoidance of intimacy altogether. A 2020 study in Sexual Medicine Reviews found that women experiencing dyspareunia show measurable increases in pelvic floor muscle tone during anticipated sexual activity, even before any physical contact occurs. The mind-body connection is powerful and real. Impact on relationships and self-identity. The implications extend beyond physical discomfort. Research in menopause indicates that sexual pain is associated with decreased sexual desire and arousal, reduced frequency of sexual activity, lower relationship satisfaction, diminished quality of life scores, increased rates of depression and anxiety, negative body image, loss of feminine identity. Many women report feeling broken, old, or less than a woman when they experience these changes. These feelings are compounded by a cultural silence around menopausal sexuality. Despite affecting millions of women, it remains an under-discussed topic even in healthcare settings. A landmark study in JAMA Internal Medicine found that only 7% of symptomatic postmenopausal women had discussed GSM symptoms with their healthcare provider, and only 25% of women experiencing symptoms were receiving treatment. This treatment gap represents a significant public health concern. Comprehensive solutions, from simple to advanced. Now for the good news: effective treatments exist across a spectrum of approaches. Let's explore evidence-based solutions, starting with the most accessible and progressing to more specialized interventions. Vaginal moisturizers and lubricants. Understanding the difference. Many women use these terms interchangeably, but they serve different purposes. Vaginal moisturizers are used regularly, typically 2 to 3 times weekly, regardless of sexual activity. They adhere to vaginal walls and provide continuous hydration. Studies in obstetrics and gynecology show that regular use of polycarbophil-based moisturizers can lower vaginal pH and improve moisture content comparably to low-dose vaginal estrogen in some women. Lubricants are applied immediately before and during sexual activity to reduce friction. They come in water-based, silicone-based, and oil-based formulations. Choosing the right products, research from the World Health Organization recommends selecting products with osmolality less than 380 milliosmoles per kilogram and pH between 4.0 to 4.5 to avoid damaging vaginal epithelial cells. Many commercial products exceed these recommendations, potentially causing cellular damage. Look for hyaluronic acid-based moisturizers, which can hold up to 1,000 times their weight in water, pH-balanced formulations, 4.0 to 4.5. Products without glycerin, which can promote yeast infections, organic, fragrance-free options to minimize irritation. A 2018 randomized controlled trial published in Menopause, comparing vaginal moisturizers to low-dose vaginal estrogen found that while estrogen was more effective, moisturizers did provide significant symptom relief for many women with mild to moderate symptoms, particularly when used consistently over 12 weeks. Vaginal estrogen therapy. Vaginal estrogen is considered the gold standard treatment for GSM and has the strongest evidence base of any intervention. How it works. Unlike systemic hormone therapy, vaginal estrogen is applied directly to vaginal tissues in very low doses. These low doses restore local tissue health with minimal systemic absorption. According to the North American Menopause Society's 2020 position statement, vaginal estrogen significantly improves vaginal dryness, dyspareunia, and overall vaginal health. Available formulations: vaginal estrogen creams, applied with an applicator, typically nightly for 2 weeks, then twice weekly for maintenance. Studies show symptom improvement within 2 to 4 weeks. Vaginal estrogen tablets, small tablets inserted vaginally using a disposable applicator. Research in the Journal of Clinical Pharmacology indicates these provide more consistent dosing than creams. Vaginal estrogen rings, a flexible ring inserted into the vagina that releases continuous low-dose estrogen for 90 days. A 2019 study in Maturitas found high patient satisfaction due to convenience. No daily or weekly applications needed. Safety profile. Decades of research confirm the safety of low-dose vaginal estrogen. A comprehensive 2016 review in Menopause analyzed data from thousands of women and found no increased risk of blood clots, stroke, breast cancer, or endometrial cancer with low-dose vaginal estrogen therapy. The American College of Obstetricians and Gynecologists states that vaginal estrogen can be used safely even in breast cancer survivors, though individual consultation with oncologists is recommended. Systemic absorption with low-dose vaginal estrogen is minimal. Blood estrogen levels remain within the postmenopausal range. Who should consider it? Vaginal estrogen is appropriate for most postmenopausal women experiencing moderate to severe GSM symptoms, particularly those with persistent vaginal dryness, despite moisturizers, painful intercourse affecting quality of life, recurrent urinary tract infections, vaginal burning or irritation. Ospemifene, the SERM option. For women who cannot or prefer not to use estrogen, ospemifene brand name Osphena offers an alternative. Approved by the FDA in 2013, specifically for moderate to severe dyspareunia due to menopause, ospemifene is a selective estrogen receptor modulator, SERM. SERMs act like estrogen in some tissues, beneficial effects, while blocking estrogen in others, avoiding potential risks. Ospemifene acts like estrogen on vaginal tissue, improving thickness and lubrication but doesn't stimulate breast or uterine tissue. A 2020 meta-analysis in Maturitas reviewing multiple clinical trials found that ospemifene significantly improved dyspareunia scores, vaginal dryness, and vaginal maturation index, a measure of vaginal cell health compared to placebo. Improvements were noted within 12 weeks and continued with ongoing treatment. Considerations: Ospemifene is taken as a daily oral tablet. Side effects can include hot flashes in about 7 to 8% of users and increased risk of blood clots, similar to systemic estrogen therapy. It's contraindicated in women with a history of blood clots or stroke. Prasterone, brand name Intrarosa, is a vaginal DHEA, dehydroepiandrosterone, insert approved by the FDA in 2016 for dyspareunia. DHEA is converted locally in vaginal tissue to both estrogen and androgens. This local conversion avoids systemic hormone exposure. Research published in Menopause shows that intravaginal DHEA significantly improves vaginal cell maturation, pH, lubrication, and pain with intercourse. A 2016 study in the Journal of Sexual Medicine followed 325 postmenopausal women using daily vaginal DHEA for 12 weeks and found statistically significant improvements in pain during intercourse and vaginal cell health, with effects comparable to vaginal estrogen. Like vaginal estrogen, intravaginal DHEA has minimal systemic absorption and an excellent safety profile based on clinical trials. The most common side effect is minor vaginal discharge. Vaginal laser therapy and radiofrequency treatments represent newer approaches gaining popularity, though the evidence base is still developing. CO2 laser, Mona Lisa Touch, FemTouch. Fractional CO2 laser therapy delivers controlled thermal energy to vaginal tissue, stimulating collagen production and improving tissue thickness, elasticity, and blood flow. Treatments typically involve 3 sessions spaced 4 to 6 weeks apart. Erbium laser, Fontenay Smooth. Similar concept using a different wavelength of laser energy. Radiofrequency, Viviv, Thermi VA. Uses radiofrequency energy rather than laser light to heat tissue and stimulate collagen remodeling. A 2019 systematic review in Sexual Medicine Reviews analyzed available studies and found that while many women report improvement in GSM symptoms after laser therapy, the evidence quality is limited by small sample sizes, lack of long-term follow-up, and methodological concerns. More encouragingly, a 2020 randomized controlled trial in menopause comparing fractional CO2 laser to vaginal estrogen found both treatments significantly improved dyspareunia, with the laser group showing faster initial improvement but similar outcomes at 12 months. Important considerations: in 2018, the FDA issued a safety communication warning against using energy-based devices for vaginal rejuvenation due to serious adverse events. However, the NAM's position statement clarifies that when used appropriately by trained providers specifically for GSM treatment, not cosmetic purposes, these technologies may offer benefits for select patients, particularly those who cannot use hormonal options. Cost is a significant barrier. Laser treatments typically cost $2,000 to $5,000 for a complete series and are rarely covered by insurance. More research is needed to establish long-term efficacy and optimal treatment protocols. Pelvic floor physical therapy. Pelvic floor dysfunction often coexists with GSM and can be both a cause and consequence of painful intercourse. Pelvic floor physical therapy addresses muscular components that contribute to dyspareunia. What it involves. Specialized physical therapists assess pelvic floor muscle function through external and internal examination, then develop individualized treatment plans that may include manual therapy techniques to release muscle tension and trigger points, biofeedback training to improve muscle awareness and control, stretching and relaxation exercises, dilator therapy to gradually desensitize tissues, education on positioning and pacing during intimacy. A 2020 systematic review in Sexual Medicine Reviews found strong evidence supporting pelvic floor physical therapy for dyspareunia, with success rates ranging from 55 to 85% depending on the specific condition. The review emphasized that therapy works best when addressing both tissue and muscular factors, combining pelvic floor physical therapy with vaginal moisturizers or estrogen often yields better outcomes than either approach alone. Who benefits most? Women with any of the following should consider pelvic floor evaluation. Pain primarily at the vaginal entrance, muscle spasms, or tightness during examination or intimacy. History of painful childbirth, episiotomy, or tearing chronic pelvic pain. Previous anxiety or trauma related to sexual activity. Vaginal dilator therapy. Vaginal dilators are smooth, tube-shaped devices in graduated sizes used to gently stretch vaginal tissues and desensitize them to touch and pressure. When they're helpful, dilators are particularly useful for women with significant vaginal narrowing or shortening, those with pelvic floor muscle tension contributing to pain, women who have avoided intimacy for extended periods, post-cancer treatment, vaginal stenosis, narrowing. How to use them. Starting with the smallest comfortable size. Dilators are inserted with lubricant and held in place for 10 to 20 minutes, 3 to 5 times weekly. Gradually, larger sizes are introduced as comfort improves. Research in the Journal of Sexual Medicine shows that regular dilator use combined with vaginal moisturizers significantly improves the ability to resume comfortable intercourse. Important note: dilators work best under guidance from a healthcare provider or pelvic floor physical therapist who can ensure proper technique and progression. Mind-body approaches. Given the psychological components of sexual pain, addressing mental and emotional factors is crucial for comprehensive treatment. Cognitive behavioral therapy, CBT. CBT helps identify and change thought patterns that contribute to pain and anxiety. A 2018 randomized trial in pain found that CBT, specifically adapted for sexual pain, significantly reduced pain intensity and improved sexual function compared to supportive therapy alone. Mindfulness-based interventions. Research led by Dr. Laurie Brotto at the University of British Columbia, published in the Journal of Sexual Medicine, shows that mindfulness training, learning to focus attention on present moment sensations without judgment, significantly improves sexual desire, arousal, and satisfaction in women with sexual dysfunction, including those with dyspareunia. Sex therapy. Working with a certified sex therapist addresses relationship dynamics, communication about pain, anxiety around intimacy, and strategies for maintaining sexual connection despite physical challenges. The American Association of Sexuality educators, counselors, and therapists provides directories of qualified professionals, couples, counseling. When pain affects relationship satisfaction, working together with a therapist can help partners communicate effectively, reduce pressure around intercourse, explore alternative forms of intimacy, and maintain emotional connection. Systemic hormone therapy. While vaginal treatments are preferred for treating localized GSM symptoms, some women benefit from systemic hormone therapy, HT, which addresses multiple menopausal symptoms simultaneously. Who might benefit? Women experiencing severe vasomotor symptoms, hot flashes, night sweats, along with vaginal symptoms might consider systemic HT, which includes estrogen and progesterone for women with an intact uterus. Considerations: systemic HT carries different risks and benefits than vaginal estrogen. The Women's Health Initiative studies and subsequent research have clarified that HT is most appropriate for women within 10 years of menopause or under age 60. Benefits typically outweigh risks for appropriately selected women in this window. Individual risk factors, personal and family history, must be considered. Regular reassessment is important, not a first-line treatment for GSM alone. According to NAMS, if vaginal symptoms are the primary concern, low-dose vaginal estrogen is preferred over systemic HT due to lower exposure and similar efficacy for these specific symptoms. Practical strategies for comfortable intimacy. Beyond medical treatments, several practical approaches can significantly improve comfort during intimate activities. Communication with your partner. Open, honest communication about pain is foundational. Research consistently shows that couples who communicate effectively about sexual concerns report higher satisfaction and better outcomes. What to discuss? Specific types of touch, positions, or activities that are comfortable versus painful, anxiety or concerns about intimacy, alternative forms of physical connection and pleasure, the importance of extended foreplay for arousal and natural lubrication, ways your partner can support your treatment journey. How to start the conversation. Choose a neutral time outside the bedroom. Use I statements. I've been experiencing pain during sex and want to talk about ways we can stay connected while I address this, rather than statements that might sound blaming. Foreplay and arousal. Adequate arousal is essential for comfortable penetration. During arousal, vaginal blood flow increases, the vagina lengthens and widens, a process called tenting, and natural lubrication improves. For postmenopausal women, this process may take longer and be less robust than it was premenopausally. Research in the Journal of Sex Research found that women who engaged in 20-plus minutes of foreplay reported significantly less pain and more pleasure during intercourse than those with shorter foreplay periods. Strategies to enhance arousal. Extend non-penetrative activities, kissing, massage, manual or oral stimulation. Focus on clitoral stimulation, which remains highly sensitive after menopause. Use fantasy, erotic reading, or visual stimulation if helpful. Reduce time pressure. Rushing impairs arousal. Positioning matters. Certain sexual positions allow for better control of depth and angle of penetration, reducing discomfort. Generally more comfortable positions. Woman on top allows control of depth, angle, and pace. Side by side reduces depth of penetration. Modified missionary with pillows under hips adjusts angle. Positions that may cause more deep pain. Deep penetration positions. Positions with less control over depth and speed. Experimentation and open communication about what feels best are key. Every woman's anatomy and pain pattern is unique. Regular sexual activity. Interestingly, research suggests that regular sexual activity, with or without a partner, may help maintain vaginal health. A 2019 study in Menopause found that postmenopausal women who engaged in weekly sexual activity, including masturbation, had better vaginal health indices than those who were sexually inactive even without using treatments. The mechanism likely involves increased blood flow to pelvic tissues during arousal and the gentle stretching that maintains tissue elasticity. This doesn't mean forcing painful intercourse. Other forms of sexual expression count too. Timing and comfort measures. Choose optimal timing. Pain levels and energy may vary throughout the day. Many women find mornings preferable when they're well rested. Create a comfortable environment. Ensure adequate privacy and lack of interruptions. Use comfortable temperature and lighting. Consider a warm bath beforehand to relax muscles. Have supplies readily available: lubricant, moisturizer, towel. Manage bladder concerns. Empty your bladder before intimacy if urinary urgency or frequency is an issue. When to see a healthcare provider. While some women successfully manage mild symptoms with over-the-counter approaches, certain situations warrant professional evaluation. Pain that significantly impacts quality of life or relationships. Symptoms that don't improve with moisturizers and lubricants after 12 weeks. Bleeding after intercourse. Vaginal discharge with unusual odor or color. Vulvar or vaginal lesions, growths, or changes in appearance. New or worsening urinary symptoms. Pain accompanied by pelvic pressure or feeling of a bulge. Possible pelvic organ prolapse. What to expect at your appointment. A thorough evaluation typically includes detailed symptom history, menstrual and menopausal history, medical and surgical history, medication review, sexual history, physical examination, including visual inspection of external genitalia and speculum examination of vagina and cervix, possibly vaginal pH measurement, and microscopic examination of vaginal fluid. Don't hesitate to advocate for yourself. If your provider dismisses concerns as normal aging, seek a second opinion. Organizations like the North American Menopause Society, NAMS, maintain directories of certified menopause practitioners, addressing common concerns and myths. Myth: pain during sex after menopause is normal and untreatable. Reality: while common, it's not normal in the sense of being inevitable or untreatable. Multiple effective treatments exist. Myth: vaginal estrogen is dangerous. Reality: low-dose vaginal estrogen has an excellent safety profile, with decades of research supporting its use. It's different from systemic hormone therapy in terms of absorption and risk profile. Myth: if I haven't been sexually active, it's too late to start. Reality: with appropriate treatment and gradual reintroduction, possibly including dilator therapy, many women successfully resume comfortable intimacy after extended periods of inactivity. Myth: painful sex means there's something wrong with my relationship. Reality: GSM is a physiological condition related to hormonal changes, not relationship quality. However, addressing it often requires couples to work together. Myth: only penetrative intercourse counts as real intimacy. Reality: intimacy encompasses emotional connection, physical affection, sensual touch, and many forms of sexual expression beyond intercourse. Redefining intimacy more broadly often reduces pressure and increases satisfaction. The future of treatment research continues to evolve our understanding and treatment of GSM. Promising areas include novel drug delivery systems. Researchers are developing longer-acting vaginal estrogen formulations requiring less frequent application, potentially improving adherence and convenience. Combination therapies. Studies are investigating optimal combinations of treatments, for example, pairing vaginal estrogen with pelvic floor physical therapy or mindfulness interventions. Personalized medicine approaches. Genetic research may eventually allow us to predict which women are most likely to develop severe GSM and which treatments will work best for individual patients. Improved energy-based devices. As laser and radiofrequency technologies mature, better protocols and device designs may emerge with stronger evidence bases. Testosterone therapy. While not currently FDA approved for GSM, research into topical vaginal or systemic testosterone for postmenopausal sexual function continues, with some studies showing promise for desire and arousal. Painful intimacy after menopause is a medical condition with treatable causes, not a personal failing, relationship problem, or inevitable consequence of aging. The silence surrounding this issue has caused countless women to suffer unnecessarily, but that silence is breaking. Armed with accurate information about what's happening in your body and the full spectrum of available solutions, you can have informed discussions with healthcare providers and make empowered decisions about your treatment. Whether you start with simple interventions like moisturizers and lubricants, pursue medical treatments like vaginal estrogen, address muscular factors through physical therapy, or combine multiple approaches, effective relief is possible. The journey to comfortable intimacy may require patience, experimentation, and persistence, but the payoff, reclaiming physical pleasure, emotional connection, and this important aspect of overall well-being, is absolutely worth it. You deserve to enjoy intimacy at every stage of life, and with today's knowledge and treatments, that goal is within reach. Remember, if you found this comprehensive guide helpful, please subscribe to our channel for more evidence-based content on women's health. Share this video with any women in your life who might benefit from this information. Together, we can break the silence around menopausal health and ensure every woman knows her options. Thank you for watching, and here's to your health and happiness.